morning, everybody. My name is Peter Löffelhardt. I'm Swiss. I just founded the MPN Patient Support Group in Switzerland. But I'm living half Switzerland, half Spain, so I'm always a little bit on the road. I'm very proud that a few people here who started with our group, that we managed today to bring so many people together, and that our project really now has been launched and is going ahead. I think most of us have experienced sometimes a problem to find the right physician for us. It's not always easy to find a physician who has the knowledge and is really deeply involved in MPM cases and knows how to treat you. And now I'm very happy person that since many years, I have PV actually since about 18 years by now. And the last 10 years, I think Dr. Besses has been treating me. And I'm doing well, basically, thanks to his support. So I would like to invite him and to the second speech. Thank you very much.
Thank you, Peter, for your kind introduction. No, this is not mine. That's definitely mine. Yes, it's yours. Okay. So my task deals of how clinicians interpret the blood work results and how we face the different situations, the different settings when we are consulted by usually an excess of blood cells. So many patients are referred from the GP or from the family physician because of abnormal blood cells counts, usually excess of blood cell counts. So this leads to what we call diagnostic process. And the diagnostic process is based in 3 points: history taking, physical examination, and additional tests. When the hematologist asks for additional tests, with a suspicion of an MPN, we usually ask for genetic test and for bone marrow examination. What blood results can lead to the suspicion of an MPN? Of course, excess of cells, thrombocytosis, increase in platelets, erythrocytosis, increase in red blood cells, leukocytosis, increase in white blood cells, but there may be some combination of all these. Please remember that yesterday we mentioned that half of the PV patients present not only excess of red blood cells, but also excess of white blood cells and or platelets. When we have the suspicion of myelofibrosis, here the situation changes. 30 to 40% of all PMF patients start with anemia. So anemia may be combined with thrombocytopenia or even with thrombocytosis and or leukocytosis in the setting of this diagnosis. So what clinicians do in the workup for a patient with thrombocytosis? Thrombocytosis is defined as an excess of more than 400 platelets. And then we have to divide the potential causes in what we call secondary thrombocytosis and what I call persistent unexplained thrombocytosis. Concerning secondary thrombocytosis, this is a very frequent consultation in clinical practice. And this is caused mainly, especially in young women, by iron deficiency. It's not unusual. By infection, by inflammation, some chronic inflammatory conditions, by surgery, by cancer, by solid cancer, or by the fact if the patient has undergone splenectomy. When the patient presents persistent thrombocytosis, it's quite wise to ask the patient if he or she has former blood cell counts in order to see if the thrombocytosis has a relatively long story. When we suspect an MPN in the face of thrombocytosis, history taking should focus if the patient should ask if has any relative with MPN or excess of blood cells, and also the presence of microvascular symptoms. Many patients don't be aware that microvascular symptoms may be the first manifestation of an MPN. For instance, headache, dizziness, visual abnormalities. So you have to ask intentionally about these symptoms to the patient who present with excess of platelets. Physical examination. When we are taking the history of a patient with thrombocytosis, usually physical examination is normal, with the exception of those patients who present erythromelalgia. Erythromelalgia is a condition in which the toes of the feet became red and very painful. This is due to occlusion of the small arteries of the feet by platelets. But usually the physical examination is normal because most of ET patients don't present splenomegaly. Additional tests, genetic test and bone marrow examination. This is the blood film of a normal individual, a healthy normal individual. You can see the distribution of red blood cells, white blood cells, and these tiny corpuscles, platelets. What happens in ET? In ET, there is a predominance of platelets in the peripheral blood film. And when we suspect essential thrombocythemia, one of the first steps is to ask for molecular genotyping. And we follow a step-based approach. So we first check for JAK2, that may be positive in 50 to 60% of ET patients. If JAK2 is negative, later we check for calreticulin mutations, that may be positive in 15 to 35% of patients. And in the case that both are negative, we check for MPL mutations with a low frequency of 3-5%. If all these three driver mutations are negative, then we check for BCR ABL in order to rule out chronic myeloid leukemia. There is a small proportion of all ET patients who are called triple negative. That's between 5 and 25%. In these patients now, in research university hospitals, next generation techniques are being applied because with next generation techniques, 1/3 of these triple negative patients present abnormal variants of driver mutations. This is the typical appearance of bone marrow in an ET. The fat is quite well preserved. There is no hypercellularity and many megakaryocytes. In more detail, you can see that these are large megakaryocytes with hyperlobulated nucleus. And even in more detail, they are big cells with this, what is called staghorn appearance of the nucleus. Moving to erythrocytosis, when a patient consults for erythrocytosis, what the clinician do? History taking, of course, to rule out, to exclude secondary causes of erythrocytosis, such as chronic lung disease, that's a frequent cause of erythrocytosis, smoking, a very frequent cause of erythrocytosis, and even in some patients, there is a condition called smoker's polycythemia, then the figures of hemoglobin and hematocrit reach very high levels. Renal disease, tumors, use of androgen, and sleep apnea syndrome. Then, in these cases, we order chest X-ray, abdominal ultrasound, oxygen saturation, carboxyhemoglobin in the case of a smoker. So several additional explorations in order to look for these secondary causes. If the patient consults for erythrocytosis and we find in the physical examination splenomegaly, then we can suspect polycythemia vera. And even if the patient presents erythrocytosis and thrombocytosis and leukocytosis. So in this setting, our suspicion of polycythemia vera is quite well grounded. Then we check for JAK2 and erythropoietin level. In clinical practice, it's very frequent that hematologists check first for JAK2 and erythropoietin level in the case of a patient who consults for erythrocytosis, because the cost-benefit of this test really provides very quick information about the cause of erythrocytosis. Then, if this is confirmed, we should perform a bone marrow examination or a red cell mass in order to demonstrate an increased red cell mass in these patients. Again, this is the normal film of a healthy person, and please compare it with the film of a PV patient. You can see that there is a dense, thick proliferation of red blood cells. Just to say some words about JAK2, that's the first check, the first test we check in the case of erythrocytosis. You know that JAK2 is a tyrosine kinase that's activated when erythropoietin or thrombopoietin interact with the receptor. Then the receptor dimerizes, phosphorylates, and produces what is called the signaling pathway. That's a chain of signals that order the cells how to behave. And this pathway provokes changes in the cell, in the replication in the cell, in the gene transcription of the cell, and so on. What happens when there is a mutation? In the case of JAK2, this is a change of valine by phenylalanine. Then the mutated JAK2 doesn't need the ligand of erythropoietin and thrombopoietin, and this is what we call constitutive activation of JAK2. That's JAK2 is permanently activated without the need of receptors. PV, this is the typical appearance of a bone marrow with PV. You can see that the difference with ET is that it's more hypercellular, and the megakaryocytes, the pathologists call these megakaryocytes in PV pleomorphic. Pleomorphic means that they are of different sizes and aspect. Moving to leukocytosis, another frequent cause of consultation to the clinic. Leukocytosis means increased leukocyte count. First of all, history taking to exclude secondary leukocytosis. That's very frequent in infections, also in acute inflammation, extremely frequent when you are taking corticosteroids, it's typical, and also smoking. Many smokers have mild leukocytosis, 12,000, 14,000, 15,000, so we have to exclude smoking as a cause of secondary leukocytosis. Physical examination. Here, this is a crucial key point, because if we found that the patient presents splenomegaly of lymphadenopathy, our diagnostic procedure will change. Besides the appearance of the blood film, if in the blood film we see a proliferation of myeloid cells or lymphoid cells, our later explorations will change according to this. For instance, we will ask for chromosome or genetic studies. In the case of lymphoid proliferation, for cell flow cytometry. In the case of suspicion of lymphoma, CT scans, PET, MRI, and so on. So this is what in clinic work we call myeloid or lymphoid proliferation. Myeloid proliferation that takes megakaryocytes, erythrocytes, mast cells, neutrophils, eosinophils, and lymphoid proliferation. It's mainly lymphocytes. So the appearance of the blood film helps a lot. When we face a leukocytosis and in the blood film there is this appearance, small lymphocytes, small mature lymphocytes with these fragments of cytoplasms that's called shades of Gumprecht, we are facing with a lymphoid proliferation, probably a chronic lymphocytic leukemia. That's the most common of the lymphoid proliferations. Contrary, if we see this in this blood film, this excessive proliferation of myeloid cells, mature and not so mature myeloid cells, we have the suspicion of myeloproliferative disorders, in this case, chronic myeloid leukemia. Myelofibrosis. Here, the setting of the suspicion of myelofibrosis changes because usually this is not an excess of blood cells. This is a combination of anemia and other cytopenias, and maybe accompanied by excess of leukocytes or platelets. But the differential fact that raises the suspicion of myelofibrosis is splenomegaly, present in 90% of all patients with primary myelofibrosis. So, according to these results and splenomegaly, we order, with the suspicion of primary myelofibrosis, a genetic test. It's mandatory to check for the driver genes, JAK2, calreticulin, and POL, and maybe optional, especially in research centers, to check for these called high molecular risk genes that have an important role in prognosis. AXL1, SRSF2, H2, IDH. The diagnosis is confirmed by peripheral blood film with a cytogenetic study, and especially by bone marrow biopsy with a cytogenetic study. Bone marrow biopsies should be stained for hematoxylin, eosin, reticulin, and collagen. Here you have the typical appearance of the blood film of a myelofibrosis. Please look at this red cell. It's a tear, like a tear, no? And also the presence of immature erythroblast in peripheral blood with this erythropoietic element. So this blood film raises clearly the suspicion of myelofibrosis. Myelofibrosis, and this is a slide from Ruben Mesa, it's a name that really includes the primary form, primary myelofibrosis, the secondary forms evolving from polycythemia vera and essential thrombocythemia, and also what now is called by the WHO organization prefibrotic myelofibrosis. Myelofibrosis, according to the view of the pathologists, is divided in these forms from no myelofibrosis to extreme myelofibrosis according to a definition that really fits in each one of these. Here's the appearance of myelofibrosis at the microscope. No fibrosis, small mesh of reticulin fibers, more dense network of reticulin fibers, and extreme massive network of reticulin fibers. According to this appearance, pathologists classify myelofibrosis from MF0 to MF3. And in the more advanced cases, myelofibrosis is really formed by extensive bundles of collagen tissue. Concerning early myelofibrosis or prefibrotic form, there is a controversy surrounding this diagnosis, but now the WHO organization has accepted to name this entity as a single entity with its own personality. And it should be differentiated from essential thrombocythemia because from the clinical point of view, early myelofibrotic or prefibrotic patients present only thrombocytosis. So the diagnosis of the clinician may be, okay, this is an essential thrombocythemia, and no, this is a different thing. So pathologists have argued that there are several differences between early myelofibrosis and essential thrombocythemia in the histological appearance. For instance, the size and aspect of megakaryocytes. In this panel, in the left upper panel, these are the typical megakaryocytes of essential thrombocythemia, mature, with the nucleus hyperlobated. And these are two examples of megakaryocytes of early myelofibrosis. Hyperchromatic, with this appearance of bulbous or cloud-like, with this chromatin difference. So this aspect of the megakaryocytes allow, with other histological features, hypercellularity, and other ones, to classify the patient from the histological point of view into essential thrombocythemia or prefibrotic myelofibrosis. And this is not just an academic job, because the distinction from ET to prefibrotic myelofibrosis has prognostic implications. So you can see that in this series, led by Tiziano Barbui and published in 2011, the survival and the leukemic transformation and transformation to over myelofibrosis was quite different at 15 years between those patients diagnosed as ET or those patients diagnosed at early prefibrotic myelofibrosis. So this is an important point. Concerning the molecular typing of MPN patients in my hospital, followed this pathway. First, we check always for JAK2, first line. Second, in the case of polycythemia vera, if it's positive, JAK2, we confirm the diagnosis. But if it's negative, then we check for this percentage, this small percentage of mutations in exon 12 that represents 2 to 3% of all patients with PV. And in the case of ET and PMF, if JAK2 is negative, we check, as we have mentioned, first calreticulin mutation, and then MPL mutation. And of course, some small groups of patients, especially in ET and PMF, are what we call triple negative patients. So as conclusions, blood work results are important information, but the diagnosis always relies for the clinician on the whole picture. This is very important. Second, genetic studies and bone marrow examination are essential, are key components of the diagnosis. Common sense and step-based tests are the best way to reach a well-grounded diagnosis. And finally, please trust in your doctor. Thank you.